Good afternoon. How we doing? A couple of housekeeping things. So, SIs and TAs have a couple of announcements to share with you. Who wanted to be the spokesperson for our SIs? I know I'm putting you on the spot. Kayla, Neve, I can't see where you are. TAs, you guys ready to give some updates? Review sessions, review study guide. That's live. That's hot. That's a hot mic.
Hi guys, how you doing? How are you feeling about the exam on Monday?
Yes!
Alright, well, we made a practice exam for you guys, and it should be out by tomorrow, so you'll have that to review with. We're also...
Hey. Thank you. I didn't do it. They did it.
We're also thinking about holding a final review session on Sunday from 12 to 1. Can I get a raise of hands who would be interested in going with that? Okay.
Whoa. That is a popular plan.
We're going to go over some of the stuff on the study guide. We're also going to have like a do and maybe even some Jeopardy games. We'll kind of tailor it to what's needed to be reviewed. So yeah, we'll send out an email with more details and we have more details as well. Thanks, guys.
Thank you. Oh, they're getting the hang of it. Clapping. Okay, awesome. So let's talk a little bit about the exam. I promised you we'd have a little time to talk about the exam today. So, 50 multiple choice, multiple guess, depending upon your situation. I'm nearly done with the exams. I write them straight from the lectures. So I actually rewatch my own lectures at like 1.5 speed, where I'm like, right? And go to slides that I really want to write a question about, and I listen to what I said. And then I write a question. That's it. I don't read the textbook and write the question. I don't recycle chapter quiz questions. It's straight from what's here. We had a couple people in office hours today. I recorded it. It's on Zoom in a folder in BB Learn called either office hours or recorded office hours. Can't remember exactly what I named it. You should probably watch it because we talk about stuff on the exam. And the summary is you're going to see histology, you'll see images, but they're going to be pulled from the lecture. Anything that we cover in here is what's fair game. I'm not going to pull it out of the textbook. I'm not going to search for some obscure histology stain on the internet that no one's going to get it. It's straight out of the lecture. So it should be obvious if you've studied. If you didn't study, I don't know what to tell you. I'm giving you as many hints as I can. You with me? Next topic. So bring a number 2 pencil. I'll probably have a couple extras if yours breaks. Hats will be backwards or take them off. You're not sitting in the back row at all. There's going to be space up front, most likely. We'll fill in the space. You won't be able to sit next to your best friend, I get it. But it's an exam, and we'll have a lot of proctors in here, a lot of eyes to help work the room. Myself, the SIs and the TAs will be the ones that will be available to answer questions specifically about the exam. The other proctors that will be here, you'll kind of not recognize them. So, and you may not know if you don't pay that close attention. So they might just be standing there, and if you raise their hand, they'll probably get one of our attention because they're just proctors. A lot of them are Ph.D. students, so it's not that they're not intelligent. They're very bright. It's just they haven't taken this class from me this semester, whereas your SIs and TAs are coming to every class with you. There'll be a format here just so that we can see what this looks like before exam day. If I brought it. You're going to turn in your Scantron alphabetically. There'll be this is a purple, and then there'll be a white A, a purple A and a white A. So if you have a colored front sheet, you'll turn it in under the colored alphabet. If it's a white front sheet on your packet, you turn your Scantron by your last name. This helps us alphabetize them quickly. And then there'll be 2 proctors taking your test packets as you turn in your exam. There was a question, can you leave early? You can, because it helps us to sort the exams as they come through. I just ask you be respectful. Don't take a phone call out in the hallway, and just know that other people are trying to concentrate. And I want to talk about concentration here in a second. Question here and then question over here. Both. Yep. You're turning them both. You're going to put your name on, I'll remind you, put your name on the packet, but then you're going to take all your answers and put them on the Scantron. The Scantron is what you're turning in. So I talked about this on Monday. If you circle an answer on the test packet and then you go to the Scantron and you bubble the wrong one, that transposition error is on you. I won't give you credit for the test packet. You have to take it and put it to the Scantron. Okay? Probably before Wednesday's class, I'm guessing. It's usually pretty quick, unless the machine's broken. And the Scantrons are like from 1942, so they have a temperament of their own. But concentration. So I'm pretty. Oh yeah, sorry. There was a question over here, and then in the back. Are Scantrons provided? Yes, Scantrons are provided at no extra charge. You're welcome. In the back. Yeah, call your dad and mom and be like, hey, can you ship me some pencils? You can use a mechanical pencil. Even a pen will work, a black pen, but the problem with a black pen is you can't erase it if you change your answer.
I just wanted to double check.
That's good to double check. Yeah, mechanical, modern-day pencil will work. Even a black ink pen will work. All right, so Monday, obviously there won't be any talking. We're going to have lots of proctors in here. I really want to create an environment that is conducive for you to do your best in an hour and 15 minutes. 50 questions in an hour and 15. There'll be 5, at the minimum, images on the screen that will correspond to questions 46 through 50. And they'll just rotate through in a loop. So if you get to 46 and the image is on question 50, don't panic. The next question will be 46. Does that make sense? Okay. Just trying to walk you through the format so there's no surprises on Monday. So it's been brought to my attention, I just need to tell you this, and I appreciate this, that there's some areas in here where there's a lot of chatting happening during lecture. I actually can't hear it, but I'm old, I can't hear much. And it's distracting. So we're all going to be comfortable with people saying, hey, do you mind? I'm actually trying to pay attention. We're not calling anybody out. We're just going to be polite. There's a lot of us in here. You know, everybody has paid to be here. And I want to make sure that you all have a great experience. So please, can we do that? Not just on Monday. I'm talking during lecture. It sounds like that's happening during lecture, and I just want to make sure that we address that. Questions on that? All right, if you have something urgent, I know you need to slip out. I get that. If you have something urgent, you have to slip out every class period, and we haven't talked about it yet, we probably should talk, or you might need to adjust your life, because if there's an emergency every Monday, Wednesday at 4 to 5:15, then something's off. Maybe your priorities. You need to have this shouldn't maybe be the priority at that time slot. I don't know. And I get that. I know this isn't the number one priority. I get that. But between 4 and 5:15, it's my number one priority. And so I want to make sure it's yours. Fair? Awesome. All right, nothing better than following a firm conversation than a couple jokes, right? What's the name of the flower you find between your nose and your chin? 2 lips. Very well done. This is all in preparation for Monday, of course. What did the cat say after his friend asked him to speak up? What did the cat say after his friend asked him to speak up? Can you hear me meow? Okay. All right, maybe it's not so good. This one was authored. I know. I think they were 7 at the time. I literally should have wrote like which daughter wrote in, what age. That would have been awesome. But one of my daughters is actually on the other side of the country. I think I told you all this. Trying to become a professional ballerina. She's in an academy with a company. And so she asked like how teaching was going. She just texted me the other day, and she's like, "Are you doing the jokes?" And I said, "I'm doing the dad jokes." She's like, "Yes." This might have been hers. Why do most fish live in salt water? Why do most fish live in salt water? I love how she put most fish, but that's true, right? There's freshwater fish. Clever, 7-year-old. Because they're allergic to pepper. Oh, man. It makes me laugh, so you can laugh at me. That's okay. I'm fine with that. And, I mean, look at how many I have, folks. We're not going to run out. They just killed it for me. We ready? One more announcement. And then I have an announcement at the end of class. Remind me. But I have one more announcement now. Our GRL textbook that you all are using, the grades go into a grade book. And the process to get them over to BB Learn is clunky at best. And in some cases, our TAs are manually entering with keys. So I want to make sure that you all own your grades. And maybe check it after exam 1, because we'll have a bunch of grades go in. After our unit 1 is done, it would be wise for you to go in, like on Wednesday, after the grade's in for exam 1, Wednesday or Thursday of next week, just check to make sure your scores are accurate. If we made a mistake, we'll fix it. We're not perfect. Okay? And if the algorithm, some of the upload actually is somewhat automated, but there's a lot of manual entering, a lot of manual adjustment. So I want you all to know that. Just being transparent, that's how it works. So I'm putting the ownership on you for quality control to check your own grades. One more announcement at the end, but now let's get into the second half of our lecture on histology and tissues. So we're moving into the types of connective tissue, and in office hours today, we actually covered a lot of this content. So there's some dialogue. It's just a couple of people and I talking about some of the aspects of this lecture. So you might find it interesting. And I know not everybody can make office hours, so I actually record them on Zoom, and they're posted on BB Learn. They're not on YouTube. The lectures are on YouTube. The office hours are on BB Learn. You with me? We've got connective tissue being a broad category or a large category. The top category that we have underneath it, loose and dense. Loose and dense. And really, most of the connective tissue will fall under these two categories, where loose is more open in architecture, and you'll see that. Dense is more, dense. It doesn't have as much open space. Blood, bone, and cartilage are unique, so they don't fall under those categories of loose and dense. But connective tissue is made up of a lot of fibroblasts, or what we call sites or cells. Sites is another term for cell. So we'll look at a lot of blasts, like osteoblasts, or we'll look at a lot of sites, like osteocytes, in today's lecture. So let's start with areolar connective tissue, which we actually talked about on Monday. We had an ID in the front of the row identify what this tissue looks like. And just to recapitulate, if I'm going to show a histology slide on the exam on Monday, it'll be out of the lecture. So it could be this one. It could be this one. And I know that colorations aren't great for everyone in this room, so I'm trying to be mindful on how we ask those questions with boxes and shapes, not just with color questions. Okay? Areolar connective tissue, it's a loose arrangement of fibrous proteins. There's a high gel component. What's the gel component that I'm referring to? Do you remember back from Monday? What was that? You can flip back to your notes. What was that gel component that we talked about? Proteoglycans. There's a lot of proteoglycans. There's a lot of space for proteoglycans. If there's a lot of proteoglycans or gel, what does that tell you about the hydration level of areolar connective tissue? High or low? Very high. You find this under epithelium, like under your skin. You find this around blood vessels. And it's a loose, open arrangement that's highly hydrated, so you get a lot of ability for cells to move. Leukocytes to move, for example. Leukocytes are a form of white blood cell. They'll come out of the bloodstream and become a macrophage. Adipose connective tissue, number 2, fat. It's another name for fat. Very obvious pattern. The white open space is a vacuole. It's a silo that stores energy. It's a loose configuration where these fat cells are adipocytes or adipocytes, depending upon how you want to pronounce it. They're derived from fibroblasts that differentiate into fat cells or adipocytes. In the adult form, as we get older, mature adipocytes no longer divide. So at some point, post-adolescence, when we become adults, you have all the fat cells that you're going to have. You actually, if you add more fat as an organism, you basically make the fat cell larger. You don't make new fat cells. When you're young, those adipocytes are dividing. But post-adolescence, you actually have the number of adipocytes that you're going to have. You find it in subcutaneous tissue. You allow it, or it's utilized to store neutral fats. It's highly vascularized, and it's rich in stem cells. And the point that I want to make about the stem cells here with this question mark, what do you think those stem cells do? What do you think those stem cells do in fat? Any ideas? So the central dogma is if you're a stable organism, you don't have new fat cells that are being added. But if you have like trauma to the skin, you have a wound, and you now need a healing response, what do you think those stem cells are going to do in that tissue? They're going to differentiate. They're going to change into something else and help a healing process. That's exactly right. They're a tremendously regenerative cell. In fact, there are companies that have created businesses around harvesting stem cells out of fat, storing them, and making them available for patients in the future for therapeutic reasons. The other thing, too, in plastic surgery, fat transposition or a fat transplant is hugely popular. Okay, we'll take fat from one part of the body and move it somewhere else to reconstruct craniofacial injuries in post-trauma accident patients. Okay, motorcycle wrecks, you name it. Breast augmentation. Okay, even in the plastic surgery and vanity applications, we'll do fat transpositions because of this rich stem cell population. You know, understanding that many of you want to move on into nursing or be a physician or physician's assistant. Some of you might become plastic surgeons or work in a plastic surgery office or work for a dermatologist. There's a lot of applications in the world of fat, which is kind of interesting. A lot of people wouldn't think so. In the theme of loose connective tissue, so loose connective tissue, just to repeat, we've got areolar connective tissue that we kicked off with. We have adipose or fat tissue, and now we're at reticular. This is areolar-like with a fine meshwork of collagen fibers. And the fibers look different. If you think through this image to this image, these collagen fibers look different. Now, the color might be different, but let's look at things other than just color. The shape is very different. The architecture is very different. So a solid histopathologist really looks at everything, not just the coloration. They're looking at the shapes and the form and the waves or the architectural patterns that are found. You see this a lot in lymphoid tissues, like in the spleen, lymph glands, lymph organs, where it allows for lymphocytes to move through because it's an open architecture, it's a loose connective tissue, and they have something to hang on to, which are these collagen fibers. If it works, I'm going to show a video during the bone segment where I want you to be able to appreciate how cells crawl on their extracellular matrix. And so this matrix environment that we're looking at, these matrices are like a jungle gym for cells to crawl on, like kids on an old-fashioned jungle gym. You know, the kind that lawyers hate, you know, the ones that are like metal bars and, you know, they swing and they fall and they hit their head. Like, they don't exist anymore because they're super dangerous. But in the old days, we used to use jungle gyms. Like, we didn't have, like, broken tires, you know, chewed up on the bottom, so it was a soft fall. And in Phoenix, we never had any shade. It was like the metal jungle gym was like 140 degrees when you touched it. You kind of had to play with gloves, but nobody had gloves. Open architecture for cells to move through. That's really one of the main functions of loose connective tissue. Let's switch gears to dense connective tissue. Dense regular connective tissue is our first one. And then we're going to look at dense irregular connective tissue. What do you think the term regular and irregular is referring to? How about someone new, sorry. Direction. So this is nicely organized. Some of you are like, ooh, that is satisfying. Everything's in a line. Right? Others, I'm just going to flip through. Others like this, like, oh yeah, let's let it go. Right? Free flow. So do you see architecturally the collagen fibers are in all sorts of different orientations here? Here, they're all neatly organized. Some of you are like this. Some of you prefer this. Some of you have a sibling that prefers that, and this is you, and you couldn't share a room together, right? So regular connective tissue, do you see how all the nuclei are sort of lined up? It actually looks like a Western blot if anybody does lab work. I know that analogy may not work in a Bio 201 class, but if you've done any lab work on protein analysis, a Western blot is a way to look at protein content, and this looks like a Western blot to me. Check me. You can Google a Western blot image and see if it looks similar. Right? I think you'll find that it's very well organized like this, if it's a good Western. High collagen content, very strong. This is what our tendons and our ligaments are made up of. So think about it. Remember, I told you on Monday, there's very few muscles in the hand at all. Most of the hand is bone and what? Tendons and some ligaments. And the muscles that control all of these movements are in the forearm. So they have to be extremely strong, and that's the collagen that has tensile strength. It resists stretching in a longitudinal plane. So what that means is if you're pulling it in the direction that it's organized, let's say all the fibers, right? All these fibers are going this way. So if I pull it this way, it's really strong. What happens if I pull it this way? It's not strong. And some of you know that because your anterior cruciate ligament went this way instead of this way in your football match, your soccer match, your volleyball match. So that's the limitation of dense regular connective tissue. Really strong unidirectionally. Poorly vascularized, we already talked about that, so it doesn't heal well. And it looks like smooth muscle that we'll get to later, but the way you tell the difference, and I'll flash back to this, is smooth muscle, you're going to see a lot more nuclei than you do on this slide. In contrast, do you think this is strong? Very strong, dense, irregular connective tissue. Lots of collagen, allows tension in many planes. And so this is a classic theme. You should be seeing this in your laboratory this week. The structure, the architecture, the anatomy dictates the functionality or the physiology. There's a reason that it's shaped like this. So it's strong in all directions. Now someone's going to ask the question that I don't know the answer to. So why isn't the anterior cruciate ligament made up of dense, irregular connective tissue? Then we wouldn't have any problems. Well, then we wouldn't have any orthopedic surgeons. So that's the best I got. I don't know why. It's a great question. I don't have the answer to it. It just is. Bless you. So here we see dermis, skin. We find it around the aorta, dense irregular connective tissue, around organs and joint capsules. The collagen is not arranged in a parallel fashion. It's irregular. And again, the whole point of that is to make it strong in all directions. The only thing I can think about with regular connective tissue in tendons and ligaments is typically the way they originate and insert, that is in the main plane of force. That's what they're really supposed to do. It's when they move out of their main plane of force that they actually can't stand up to tension in different directions. Okay? And some would argue that extreme cases of pulling on it in football injuries, hockey injuries, volleyball, softball, you're taking it to an extreme, right? And some individuals are more prone to these types of accidents because their dense, irregular connective tissue is weaker than others. That's just the genetic diversity that we have. So there is an answer, not necessarily a great one, because I don't really know why, but it's at least a hypothesis for you. Okay, let's move to cartilage. Some would argue in the literature that there actually is some blood supply. We've got white cartilage, and then there's usually a ring of red cartilage around it. And orthopedic surgeons, a lot of times what they'll do is they'll come in orthoscopically, and they try to kind of put holes in the outer ring of the cartilage where there's some limited vascular supply to see if they can encourage bleeding so that they can try to reperfuse the cartilage and see if it'll heal. But it doesn't work great. So general conventional wisdom is there is no blood supply, although your neighborhood-friendly orthopedic surgeon would tell you, well, it's relatively avascular, I agree, but I wouldn't say that it's no blood supply. But I just want you to understand why there's sort of that argument within the field. So this is cartilage. It's full of these cells that live in little caves known as lacunae. And this is a picture of hyaline cartilage. And we're going to see a couple more pictures of hyaline cartilage. And the real telltale of hyaline cartilage is it's got this googly eye or this like fish egg looking appearance. I think in the textbook it talks about fish egg or frog eggs, right? Frog egg appearance. The perichondrium is a layer of dense, irregular connective tissue which surrounds the cartilage when it's in a developing bone. So it is protected by dense, irregular connective tissue. It's kind of in a capsule. I want to point out, too, in lab, you're going to be doing a lot of this identification. So this is where we're in great synergy right now, this week. But you're going to go in far more depth in lab about different preps. And you probably won't have from your lab instructor the statement of, hey, I will only test you on what I show you in my lecture deck. They're going to push the envelope for you on identification in lab. And that's the way it's supposed to be. Here, I want to focus on what's the purpose, what's the function, where does it live, why is it there? So let's look at hyaline cartilage. Like the previous picture, this is another two examples of hyaline cartilage down here and on the lower right. You can see a chondrocyte living in this little lacuna. So some of you are wondering, how do I spell that? Well, here's how you spell it, Lacuna. And you've got a chondrocyte that lives in this little cave. And that chondrocyte is what makes cartilage. Hyaline cartilage is white, glassy. It's the gristle that you find in a lot of meats. If you're a vegetarian, I apologize for the analogy. You're probably like, ugh, that's why I became a vegetarian. Okay? It's the most abundant type of cartilage that there is. And of all your cartilage, 40% of it is made up of collagen. to try to give it the tensile strength that's necessary. You're going to find hyaline cartilage, the trachea, the tip of your nose, costal cartilage, like between the ribs and the sternum, and at the ends of your long bones. Elastic cartilage. Very, very different in appearance. Do you see the density of chondrocytes and elastic cartilage? That should be a telltale giveaway that you're not talking about hyaline cartilage, you're talking about elastic cartilage. Secondarily, there's elastic fibers. Now, these are these black squiggly lines that are labeled by these arrows that happen to be red. There's more up here. There's some right here. They're all over the place. Right here, there's like 1, 2, 3 fibers. This is a cell that I'm circling, and those fibers are coming right out of that cell. Let me see if I can circle it with the... So this chondrocyte right here, and then here's an elastic fiber coming out of it, here's an elastic fiber, and then here's one coming up here. External ear, the epiglottis, is where you're going to find this. Structures that actually need flexibility, aggressive flexibility. Fibrocartilage. This is our last type of cartilage, and then we're going to move to bone. It's less firm than hyaline, more compressible. It tends to be a link between hyaline and dense, regular connective tissue. You see these wavy lines when we talk about architecture or shape? Look at these wavy lines. So, strong in which direction would you say? Stronger in this direction and this direction, correct? If you pulled kind of from the lower right of the picture and you pulled from the upper left, does that make sense? It's going to be stronger in this direction. It's going to be really weak in this direction because you're just pulling those layers apart. I think these look like layers of noodles, like in a lasagna, I think is what your book talks about. Or you see just like little layers like in a riverbed where sand is deposited. This wavy line. So you have far less chondrocytes than you see in elastic cartilage, for example, or that you see in hyaline cartilage. But in hyaline cartilage, you don't have this wavy architecture that helps with this linkage between the two different types of tissues. You're going to find fibrocartilage, intervertebral discs, pubic symphysis. The pubic symphysis is the point at which your pelvic comes together right at your crotch. Knee discs, menisci. This is fibrocartilage that you tore if you've torn a disc in your knee. These chondrocytes are typically found in a row. So you can see that they exist in this sort of diagonal row, and they line up. Question?
How are they getting oxygen if there's no blood flow in the cartilage?
It's a great question. How are they getting oxygen if there's no blood flow in the cartilage? Because they're near a blood supply that's near a bony surface. And the bone is well vascularized. So that's a great lead into this picture. So let's talk about vascularization and bone. And let's compare and contrast it to cartilage. You tear cartilage, it doesn't heal well. You break a bone, really 6 to 8 weeks later, it's stronger than it was. Right? So what's the difference? The biggest difference is the vascular supply. So this question up front was a great one. Cartilage actually doesn't heal very well. It has a very low metabolic rate. It's not really doing much. These little cells are sitting in a cave kind of watching, binge watching Netflix. They don't really do much. There's not a lot of turnover in these 3 different types of tissue. They just need enough diffusion of oxygen to stay alive, stay afloat. But in bone is constantly remodeling. constant turnover. Right now it's remodeling while you're sitting here. You're like, what? It constantly remodels. And here's why. You store so many calcium ions in bone, and you need those for homeostatic regulation. So you want to liberate them. You stimulate osteoclasts to break down the bone, release the calcium, and then you reshape the bone by taking calcium, giving it to the osteoblasts, and laying down a new scaffold. You're constantly remodeling your bones. As you work out, as you exercise, as you play your sport, do your craft, you do your intramurals, any active activity that you like to do, your bones are going to remodel based upon the force that they're put on. This is one of the reasons for these postmenopausal women that we talked about on Monday. One of the prescriptions, especially by physical therapists and physicians, is weight-bearing exercise for these women. We want you to do weight-bearing exercise. That might be small weight dumbbells, walks around the block, lifting, not heavy weight, but doing weight-bearing exercises where you're moving and you're making the bones take the tension of the muscles that are attached to them so they feel the force. They feel the force, they're going to respond. I'm going to show you a video. Two different types. We have cancellous and we have osseous. Cancellous is also known as trabeculated bone or spongy bone. Why are there three different names? Because tons of different researchers like to categorize what this bone is, and they named it different stuff. Osseous, cortical, or compact. Second type of bone. Hydroxyapatite, HA, is a natural occurring mineral that's found in bone, and it's referred to as the bone mineral that you're going to kind of see in this video. It's part of the scaffolding of the architecture. There's a special arrangement of the vasculature in the bone. So if you can appreciate, this is a cross-sectional view. Let's say we took the lower part of my leg, we embedded it in that resin that we talked about. We're doing histology. So we actually take a 30 or a 40 micron slice, we put it on a stub, we grind it down maybe to 20 microns, and then we polish it. And the osteons are columns that run this way. So let's pretend it's like this hydro flask, and now you're looking at the osteon like this. So the central canal is right down the middle, and that's the main blood that houses the main blood vessel. And that's where a lot of the nutrition and the oxygen is. And you can appreciate, hopefully, here's one osteon, and do you see the concentric circles around it? You can appreciate this cylinder here, and then here's another cylinder. And then here's another one that's kind of cut off in this image. Here's a piece of half of a cylinder. Here's another cylinder down here. Here's a cylinder here that has a little bit of an artifactual defect, probably because of the grinding or polishing. This cylinder center to this cylinder center is always a defined distance in your body as you remodel your bone. And it's limited, the size of this is limited by the diffusion distance of oxygen. So for example, oxygen in tissues has a diffusion distance of about 250 microns. And so an osteon will only, you don't have a bone that's one giant osteon. Because it would be, the stuff out here, the osteocytes, way far away from a blood supply. So that's why you build another osteon. So this bone cell that's right here is closer to this central canal, so it's going to be maybe 200 microns away from here. And that's how your bones dictate when they show up with a new osteon, by this principle of oxygenation from a blood supply. It's pretty fascinating. You have the cannuliculi that actually move from one lacunae to another, bringing blood supply from one cave to another. It's like, it's like an internet connection from one cave to another, so they can both watch television or surf the web, right? They're getting their nutrition. So this special arrangement is quite fascinating in bone, and it's very unique to bone. Cancellous bone has the trabeculae. Trabeculae is a Latin word that means small beam. And so in Latin, when we say small beam, the original Greek discovery was, hey, there's these struts or these beams that hold things together within trabeculated or cancellous bone. And it's like a spicule of bone. And it's labeled here with this T, and it's this dark pink structure that you see. And then in between them is the marrow space with adipocytes or fat cells. And why? Well, the marrow space is hugely regenerative. The marrow space in bone gives rise to red blood cells and white blood cells. Red blood cells bind oxygen and transport it through your blood. White blood cells are the foundational cell of your immune system. So without this, we wouldn't actually function very well at all. Now, when we do a bone prep, we actually can decalcify it, where I talked to you about there's a resin in the scorpion that goes in the resin, or there's wax. So if you want to take bone and you want to look more at the cell shapes, the resin processing compromises a lot of the cells. You can't see that level of detail. So what you do is you decalcify the bone. And then you can put in wax and the bone becomes soft. And you can do this with an eggshell. You've ever decalcified an eggshell? How did you do it? Put it in vinegar and the calcium, elutes out. So not real complicated, but this is a decalcified bone prep. In lab, you might have a slide that says decalcified bone, and some of you are like, what the heck is that? It's referring to the preparation of how they made it. So that's this slide right here, and I just took it and labeled it. So what I want you to see, and I see the picture in the back, or the hand in the back, I want you to see this picture, and then I'll take your questions, and then we're going to watch just a quick little video on this process. We've got 3 different cell types here in compact bone. And you've got an osteocyte, which should be pretty obvious because it's sitting in a lacunae. It's nice and comfortable. Nobody's bothering it. It's got a nice lot, acreage, nobody else around. Okay? This is an osteoblast. This cell, osteoblast, is a bone-building cell. So just remember the alliteration. Bone building, osteoblast, builds bone. BBB. Whatever it takes to help you remember. So this wave front, I'm going to show you a video that shows this in cartoon format, is laying down new bone going this direction, upwards. Can you kind of visualize that? As you see all these cells lining up and they're moving that way, and you can see this is a darker pink, this is a lighter pink, they're moving, the front is moving that way. Well, behind it right here, these are multinucleated osteoclasts that are breaking down bone, and they're chewing it up in this direction. So you got osteoclast chewing the bone up here and osteoblast laying it down. And that's the constant turnover that's happening in you and I 24/7. And it all has to do with the forces. If you're more sedentary, you have higher osteoclast activity. If you're more active, you have higher osteoblast activity. So that equation of osteoblast-osteoclast activity has a lot to do with your exercise level or your physical level. Individuals, unfortunately, that are bedridden, our elderly patients, there's a lot of osteoclast activity and they're at high risk of osteoporosis, meaning you have more remodeling of the bone that's eroding versus laying down new bone. There's a question back here. Yeah, so osteogenesis imperfecta is an imbalance or a genetic abnormality where osteoblast activity is compromised. And there's different levels of deteriorated osteoblast activity. Yeah. We'll get into, if you continue with me and you take 320 pathology, we'll talk a lot of more about different types of diseases, and it gets kind of, I say it gets kind of fun in a nerdy kind of way because this is what we all like, right? We want to study this stuff. Sometimes you have to be careful how you say that, but it's just fascinating. But you first have to learn how the biology works, the physiology works, before you can understand how it goes wrong. And you have to know both so you can treat. And that's where a lot of you are trying to go in the future, right?
So you said high activity would increase the osteoblast rate.
Yeah.
Could you, if you were to kick a tree over and over again for a year straight, would that bone in your leg get better than the rest of the bones in your body?
Yeah, okay. So let me repeat for the lecture video and those that couldn't hear. So if let me rephrase in a slightly different way. If bone remodels based upon the force that it's placed under, and if you have more force put on the bone, meaning high physical activity, tension, weight-bearing activity, osteoblast activity is favored and you're going to lay down more bone. That is true, scientifically proven. The question was, if you were to say randomly kick a tree for training purposes over and over and over again, would the bone underneath there remodel? And the answer is yes, it would. There's actually science to support what you're describing. I don't advocate that everyone goes out and kicks trees. You'll probably stop after about 2 minutes, but some of you won't. And it's an interesting training regime, but it actually does work. Yeah. And many of you that know the martial art that we're kind of referring to, it's been around for thousands, hundreds of years probably. I don't know about thousands, but hundreds of years. And did they know about this? No, but they discovered that bone was stronger or more intense than maybe a bone that didn't go through that type of repetitive injury, for lack of a better term. Yeah?
Could there be an unhealthy amount of osteoblast growth due to activity, or would that be more of a not disease, but
Yeah, so the question is, could there be an unhealthy amount of osteoblast activity? And the answer is yes. If you lay down too much bone, you pull out calcium out of the body, now you could be calcium deficient. So that's one problem. Right? Who cares about calcium being low in the blood? Well, your muscles need calcium in order to contract. Your heart has to have calcium in order to contract. So you need the right amount of calcium in the bloodstream. So that is possible. The other one is there are types of diseases, endocrinology diseases, disorders, where we're talking about thyroid imbalance, and you can actually have too much bone building in certain individuals, and then you get some bony types of defects that form. So I'm talking about giganticism or acromegaly. So if we look at, does anybody know Andre the Giant? The late Andre the Giant. So he had a tumor, actually, a pituitary tumor in his brain. And you'll learn more about endocrinology in 202, but it was an overactive pituitary that put a lot of activity on his thyroid, causing him to release a lot of thyroid hormone and growth hormone. And so he grew really big as a kid. And then when the growth plates close, that bone continues to grow. And so now you get what's called acromegaly, where you get bony deformities. Make sense? Yeah.
if repetitive use of bone strengthens it, how does stuff like stress fractures occur?
So stress fractures, and we'll talk about the skeletal system. We'll get into some fractures later in the semester. Stress fractures will take place where you've got, how those osteons are formed. You'll have too much stress in an area where the osteon formation isn't strong enough yet to handle it. And then you'll get a fracture that takes place. I mean, the good news is they'll heal as long as you pay attention to it. Okay, let me play this video for us because it kind of puts to, instead of still pictures and me trying to explain and have you visualize, this company Amgen, I totally stole this from Amgen, shows this video that's quite, I think, helpful.
The skeleton changes across the human lifespan. This is characterized predominantly by bone formation and growth throughout childhood, followed by a gradual loss of bone density that begins in early adulthood that can accelerate significantly in older adults. The density of bone is modulated by a group of cells including osteoblasts. which are multinucleated cells that resorb bone, and osteoblasts, which refill the resorption cavities.
See how it's leaving this tail of bone behind it?
Osteoclasts anchor themselves to the surface of bone. This creates a microenvironment underneath the cell, which is referred to as the sealed zone.
Those are the nuclei, multinucleate.
Within this zone, the osteoclasts create an acidic environment that dissolves the bone's mineral content.
Releasing calcium.
Mineral content of the bone has been dissolved. Enzymes released from osteoclasts remove the remaining collagenous bone matrix to complete the process of resorption. Following resorption, osteoblasts move into the resorption space and start to produce and deposit organic matrix called osteoid. Osteoid, a substance made predominantly of collagen, forms a scaffold in which minerals including calcium and phosphate begin to crystallize. Some active osteoblasts become trapped within the matrix they secrete and thereby become osteocytes. Other osteoblasts will undergo apoptosis.
Okay. So those are the three players that I want you to be familiar with. And I just wanted you to be able to see a visualization of what that looks like by, one artist that's trying to put into motion what's going on and what we just talked about. Questions? Does that help? In the back. So the question is from the back, when an individual donates bone marrow, do the would you ask? The osteoblasts go into overdrive. So not necessarily. It kind of depends on how much marrow is taken. And, why would you donate bone marrow? Well, in some cases where patients have a leukemia, a cancer that affects the white blood cells, the origin of those white blood cells comes out of the bone marrow. So then you would go to a bone marrow transplant, which isn't simple. It's easier said than done, and move from one patient to another bone marrow. The marrow will be replaced in that donor patient. It takes about 8 weeks. And depending upon how much tissue is taken, it might take a little longer or take a little less. But they don't need to go into overdrive, as you asked. And you have plenty of marrow. You don't need a lot. Usually think of it more of a marrow transplant as you're taking a small amount out of one patient and you're seeding another patient. You don't completely replace all the marrow in the patient, because then you'd put the donor patient in jeopardy. All right, let's talk about blood. So blood is actually a connective tissue. And we discuss it in heavy detail in 202, but I want to introduce it here because it fits into the category that we're talking about. And what I want you to be able to appreciate is it's a liquid cells, white blood cells, like what we were talking about with these below in numbers, and red blood cells. And the white blood cells are the two unusual cells in the middle of the screen. And the red blood cells are all the other ones that are like biconcave. They have little dimples on both sides. It looks like a dinner plate on both sides of the cell. And the cells live in a matrix. And that matrix is the plasma. And the plasma is a rich proteinaceous fluid that can actually become solid. And you all know it becomes solid when you have a cut, so you don't exsanguinate and die, bleed out. So this is just another type of connective tissue. All right, our last little segment is muscles and nerves, and then we're going to do another little practice quiz with some histology, so stick around for that. On muscles and nerves, what do muscles do? We're talking about the tissue now, and then we're going to talk about skeletal muscle and cardiac muscle, mostly skeletal muscle as it contracts in our muscle physiology lectures. But their purpose is to shorten. And as they shorten, they cause movement in our appendages throughout our body. They have specialized architecture to allow this type of function. I told you in one of the early lectures of this semester about the actin and the myosin arrangement inside the cell. And we're going to look at that in great detail in our muscle physiology segment later this semester, where those two pieces of protein slide across each other and allow for contraction to take place. It's highly cellularized. It's well vascularized. If you've ever torn a muscle, it actually heals really quickly. Unlike tendons and ligaments and cartilage, muscle heals very quickly like bone does. These elongated cells are muscle cells. We have a special term for them. We call them fibrils. So we're going to start introducing some new terminology throughout the semester, but I want you to be able to appreciate that a muscle fiber is a muscle cell. Those two terms are synonymous. And they have these cytoskeletal proteins, actin and myosin, that they use for contraction. We have skeletal, we have cardiac, and we have smooth. And those are the three types of muscle that we need to be able to identify. Skeletal muscle is under voluntary control. You move it, you contract it. You can think about making it go. Some of you would say, well, what about reflexes? Well, what you're doing with reflexes is you're actually stimulating a nerve then to come back and fire and say, contract the muscle. So that's correct, but mostly we say they're under voluntary control. They attach to bones via tendons, elongated, multinucleated cells that are striated. So what I want you to be able to appreciate are these hash marks, these striations. It almost looks like it's ribbed. And the cell goes from the top to the bottom. That's why it's called a fiber, because it looks like a fiber. This cell has 2 nuclei in this particular field of view. So they're multinucleated. Cardiac muscle, muscle of the heart, under involuntary control. We're not sitting in class going beat, 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 beat. Oh, whoops, beat, 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 right? That would be an arrhythmia, and you probably wouldn't be here. You'd be getting treated. They're under involuntary control. They're branched, and they have these single nuclei, and they're striated. And the striations are going to become important when we talk about actin and myosin. That's what you're seeing. These striations are the actin and myosin organization inside the cell. So this is organized very similar. It has that striation, but they have these very distinct discs, intercalated discs that connect one muscle cell to another, and they allow for them to communicate. The cells actually do like a handshake, and then they share information on when to contract. So then this one contracts, and the one next to it contracts in synchrony. So you wouldn't want your cardiac muscle to be out of sync when it contracts. And if it is out of sync because you have a lesion that blocks these intercalated discs, then you have a cardiac arrhythmia, and it might lead to a heart attack. Smooth muscle, no visible striations. That's the best way to tell. Uninucleated, single nucleus. Involuntary control, internal organs, the esophagus, all throughout the alimentary canal, in the middle lining of blood vessels to allow for pulsatile flow. And I told you I was going to compare and contrast this slide to this slide when we got here. Do you see the differences? So obviously, don't pay attention to the color. I want you to pay attention to the fact that this is rather organized and it looks nucleated. And smooth muscle, and that's dense, regular connective tissue, smooth muscle has a lot more nuclei. The shape of these cells are like a spindle, or what we call fusiform. They're kind of narrow in one end, fat in the middle, narrow at the other end. Kind of like a football. Then our last cell that we need to categorize, or tissue, is nervous tissue. Please don't get up and leave. You're going to want to stick around for the last 15 minutes. I promise. 2 cell types, neurons and glial cells. The neuron is the giant thing in the middle of the picture. It's got a big nucleus. It allows for an action potential, nervous information to be sent. You have dendrites. Dendrite in the Greek actually means tree. Dendrite means tree. And the dendrite actually receives the electrical information from another neuron. And then it sends it down to the cell body, which is what you're seeing in the middle of this picture, or the soma. And then it'll transmit it down an axon to go to a synaptic end bulb to send it to another neuron or to a muscle if the muscle needs to contract. Bless you. Glial cells. Glial cells are all these nuclei that are out here outside, hanging out around the neuron, and they are supporting cells of the neuron. And we'll get into that in this lecture, in later lectures when we look at neurophysiology. We'll look at what these glial cells do. Some of them allow for nutritional exchange. Some of them act like small little macrophages to help clean up damage in the nervous tissue. Right? Some of them actually support the neuron, not just with nutrition, but actually removing waste products. They're far more numerous. They're 9 to 1. Glial cells outnumber the neurons 9 to 1. So for every 10 nervous tissue cells, 9 of them will be glial cells and 1 of them will be a neuron. And the types that we'll get into later in lecture of the glial cells are different categories, like Schwann cells or oligodendrocytes, satellite cells, okay? Microglial cells. The Schwann cells function to actually wrap a portion of the neuron, the axon, with a lipid layer, like an insulation, like insulated wire. You ask why? Well, that specialization allows for the electrical signal to move more quickly. And I'll show you how that works. It's kind of cool. But just tuck that away for later. So these are the types of tissues that we wanted to cover today, and kind of wraps up what we're going to have on exam 1 on Monday. Questions before we shift gears? No questions? It was either crystal clear or it was super boring. Okay? Hopefully it was. Okay, great. Thank you so much, because those are only 2 options.
Were you making, I know you went on about this for a little bit, but were you trying to make a point that smooth muscle looks similar to...
Dense, regular connective tissue?
Yeah, but you notice it, or you can differentiate them by...
The number of nuclei. So the question is, let me paraphrase. You kind of droned on and on and on, Dr. Keller, about the differences between, no, I'm just kidding, give me a hard time, about smooth muscle and dense regular connective tissue. I was just trying to make some comparisons, because some of you have asked me that question. I'm having trouble just differentiating between the two. And the big difference is you're going to see more nuclei in the smooth muscle. So here's what I want to do. You have these slides, practice quiz, and we're going to walk through them. Okay, they should be familiar. We're going to walk through them. They're fair game for the exam, and I would write down the answer and then stick around for the bonus assignment at the very end. So let's all take time to think what the answer is, and then we'll see a show of hands. What is this histology? And this is how it's going to be on Monday. It'll be something exactly like this, and you'll bubble in on the Scantron. I don't want there to be any surprises on Monday. I want you all to come in and say, okay, I know exactly what this is going to look like. Obviously, exam 2, 3, 4, and then the final, you'll be like, yeah, this is old hat. I'm super tired of him by now. But Monday, I just don't want there to be a lot of surprises. And I know sometimes not knowing how it's going to look is the scariest thing in a class like this. So that's why I'm taking a lot of time in class, in lecture, to walk you through what it's going to look like on Monday. So you're calm. Okay, and you can focus on the content. Yes? Don't answer this. You just have a question? It is a question. Go.
Are the questions that will look like this the ones that will be on the board, like only the last 5? Or is it any question?
Any question in Unit 1 could become an image question on the screen. Any question in Unit 1 that we covered in lecture.
But it's only like the last 5. The rest are just...
What do you mean the last 5? I don't know what the last 5 means. Oh, the last 5 questions of the exam. Yeah, just the last 5 questions on the exam are going to be image questions on the screen. I'm not going to, I think that would be horrible. Your necks would hurt. You'd be like, 50 questions like that? I mean, you're going to have a test packet, and then this will be relaxing. You're like, relaxing? Because you'll be like, oh man, my eyes hurt from looking at this test packet. You know what, I'm at 25, I'm going to hit the pause button, I'm going to answer some of those up there and take a break, and then go back. It kind of breaks it up a little bit, okay? All right, what is this? Stratified columnar, raise the hands. Transitional, simple squamous, simple columnar, stratified squamous. Simple squamous, have it with C. Well done. What is this? Give you a second. You should actually have these pictures in your slide deck. You just don't have the answers. Okay, hyaline cartilage, A. Elastic cartilage. Adipose connective tissue. That's what CT stands for. It's not CAT scan. Fibrocartilage. Areolar connective tissue. Areolar connective tissue has it. E. Well done. How about this one? What is it? Stratified columnar epithelium, transitional epithelium, simple squamous epithelium, simple columnar. Everyone's a holdout here. Pseudostratified epithelium. Some of you say, how come it doesn't say ciliated? It's still pseudostratified. To be more correct to say it's ciliated because you can see them there. I would agree. But don't get caught off on that one. Like if you need to ask that question on Monday, like, hey, Dr. Keller, I don't see anyone, but it's got to be this one, but it doesn't say ciliated. Like, are you trying to trick us? Like, no, don't worry about that. The ciliated shouldn't make a difference. Where are you most likely to see this tissue? So it may not just be what is it. Like that's kind of a lab. Now it's like where are you going to find it? So you kind of have to know what it is, and then you have to think about where you're going to find it. I'll give you a second. All right, let's go. A, GI tract. B, lining the kidney tubules. In the epidermis, part of the skin. Covering an organ. Reinforcing a joint capsule. Definitely less people participating, which is totally fine. So what is this epithelium? Let's start there, in the back. Simple columnar epithelium. Simple columnar. You'd most often find this in the gastrointestinal lining, the GI tract. How about this one? What is it? This is like a straight lab one, actually. I don't know if we really covered it in the lecture. We're covering it now. It's kind of straight from lab, so we'll just kind of go through it. Dense regular connective tissue, adipose connective tissue, reticular connective tissue. Ooh, can't fool you all. Dense irregular, areolar. It is reticular connective tissue. Well done. How about this one? Give you a second. Stratified columnar epithelium. Hands. Smooth muscle. Stratified cuboidal. Dense irregular connective tissue. Areolar. It is stratified columnar. And I know some of you are stratified cuboidal. Stratified, I don't know of many places where there are stratified cuboidal. I'm not sure it really is in existence. Stratified columnar, these are more elongated. You see how long these are? They're more like columns. Not the best picture. I probably wouldn't use this one on the exam. It's a little, it's not sharp. I don't like how it's, this one's sharp. I like this one. Sharp meaning like in focus. Small black fibers in this slide are what? if you know what the tissue is first, right? And I'm pointing to these sort of squiggly lines, not these large, fatter, they happen to be pink, but these are more narrow and squiggly. Okay, here we go. Neuronal axons, collagen fibers, reticular cells, elastin fibers. I love it. You guys are awesome. Elastin's kind of my baby, so I love that. Blood vessels. Okay, you're right, D. So smart. Y'all are so smart. Ooh, okay, this one. So here we go. This one could be confusing. This is a great example. What is the major function of this tissue? I'm not asking you what it is, but you kind of need to know what it is to tell me what it does. So think about what you think it is, and then let's connect it to what it does. Yeah, and I don't mind a little chatter here. Some of you are like, oh gosh, we kind of got our hand slapped for talking in class. This is where you're supposed to participate. That's fine. Okay. Movement of ingested food through the digestive tract. Okay, a couple. Protecting the body from the external environment. Connecting bone to bone. More of you. Absorption of nutrients. Storage of calcium phosphate crystals. It is bone to bone. Connecting bone to bone. This is dense, regular connective tissue. Dense, regular connective tissue. More nuclei than the one I showed you that looked like a Western blot that I kept talking about. But if you compare it to smooth muscle has a lot more nuclei. What about this one? Stratified columnar. Oh, no, you can change your mind, that's fine. Just erase it really well on the Scantron. There you go. Yeah, you in blue, I'm talking to you. Smooth muscle. Transitional epithelium. Nailed it. You guys nailed it. All right. Stratified cuboidal epithelium, but we're moving on. You guys are bright. Okay, this is a nice one for us to look at. First, what is it? And what do you call a mature cell in this tissue? Let's go through it. If you have specific questions, just come see me afterwards, okay? If you have specific questions about the slides. Just want to make sure we get through them all, and then I got to give you an assignment. A, fibrocyte, adipocyte, fibroblast, chondrocyte, epithelial cell. These are adipocytes, fat cells. They just are colored differently, but huge vacuoles, huge lumens with the nucleus pushed up against the side. For those of you who can see it, I mean, obviously they're orange in the middle of the cell, but more importantly, the shape is they're wide open. An immature cell in this tissue would be called what? What is this tissue? What is it? What kind of tissue is it? Cartilage. What kind of cartilage? Fibrocartilage. So what would you call a immature cell? A fibroblast. What is it? This one's going to be tricky. Focus on this one. This is the kind of view we've been looking at. This is actually a cross-sectional view. You cut it here and then you look at it on end. Skeletal, dense, regular connective tissue, smooth muscle, cardiac muscle, or dense, irregular. It is smooth. There aren't any striations. All right, last one. What is this? What's the structure that the arrow is pointing at? It's a dendrite. All right.